There you go.
Okay. So this week, we have Lisa Butterworth from Lared. She works in women's health at Lared Health Center. Lisa's education, she has a master's in nurse midwifery from Vanderbilt University. She's a certified midwife with over 12 years experience in Maryland and Delaware. She joined Lared Health Center in 2023 as the clinical operations director of women's health, and she leads a team of midwives, nurses, OBGYN, and provides care for over 700 women in Sussex County. Before joining Lared, she worked at a federally qualified health center in Maryland. Thank you, Lisa, for joining us and sharing your information. I'm going to turn it over to you.
Hello. Yeah, so as she said, my name is Lisa Butterworth. I am a nurse midwife at Lared Health Center in Delaware currently. And I'm going to go ahead and right into the presentation because I give a little bit more of my bio in that. Just give me 1 second.
You've got it.
Okay. We good? You can see the PowerPoint?
Perfect.
Okay. So I work in women's health. A little bit about my education. I graduated high school in Tampa, Florida in 2004, and then started my undergraduate studies at University of North Florida. And then I received a bachelor's of science in nursing. I decided that I wanted to go straight through to get my advanced practice degree. So while I was still in my nursing program, I had started applying to my master's program. I only applied to one school, and it was where I wanted to go, and I was hoping I got in, and I did, which was great. So I worked as a registered nurse for only about 8 months before my master's degree started. And then I continued to work as a nurse part-time and per diem, which is kind of like as needed throughout my education. I got my master's of science in nurse midwifery at Vanderbilt University in Nashville, Tennessee in 2009. In 2011. And then that was in December. And then in January, I started my first job in Salisbury, Maryland, at an FQHC. An FQHC is a federally qualified health center. So those are health centers that get some government funding because they serve an underserved population, either uninsured or underinsured. The unique thing about the practice in Salisbury is we had everything. We had the uninsured, the state insurance, and private insurance. So we had kind of all payers basically. And then I was there for about 7 years, and then I did almost 2 years with BB Medical Group, and then went into private practice with 2 physicians. And then that led me to my administrative position that I have now at Lared Health Center. I also work per diem up in Dover at Bay Health Kent, where I deliver babies there. So currently at Lared Health Center, I'm the director of women's health. We care for uninsured and underinsured population in Sussex County. For OBGYN, we serve a large population of uninsured pregnant and childbearing women. This is predominantly the Hispanic migrant population. So they're not eligible for any insurance. We provide prenatal care, contraception care, STD testing and treatment, cervical and breast cancer screening, among other things for gynecological care. Lared also offers primary care, pediatrics, behavioral health, and dental services as well. So basically these patients have a kind of a one-stop shop, and they have a lot of resources to help them make sure that they get the care that they otherwise wouldn't be able to have access to. We have a lot of resources to help address social determinants of health. Like we have a whole team of transportation services. So they're community health workers that go out and pick up patients and bring them not only to our offices for appointments, but when we refer them to specialists and they need transportation to that, which is common in obstetrics, our transportation provides not only the travel there, but they provide interpretation services at the specialist, which is really great. We have a whole team of interpreters, which is a phenomenal program that we offer for these patients. And we have a lot of connections to other community outreach programs for different things like domestic violence, food needs, housing needs, diaper needs, all kinds of stuff. So a little bit about women's health. There are several types of women's health providers. This probably won't include all of them, but this is the most common types of providers. So there's an OBGYN, and there's MD or DO, and they practice obstetrics and gynecology. These providers get a mix of office practice, surgery, and hospital practice. They perform vaginal and cesarean deliveries, gynecological procedures and surgeries. A lot of them get extra training to do robotic surgeries, which is really interesting. Their schooling, so an OBGYN does a 4-year undergrad, and then they do 4 years of medical school, and then another 4 years of residency in OBGYN. So about 12 years in total. A nurse midwife, which is what I am, we are advanced practice nurses, and we provide care from menarche, which is the female's first period, all the way through menopause and beyond. We provide prenatal care, we manage labor, and we do vaginal deliveries. With vaginal deliveries, we do suturing and repair. You can get extra training in things like using a vacuum and doing more complicated repairs as well. We provide gynecological care. This is actually a large part of what we do as well. So birth control counseling and inserting, depending on what kind of birth control. There's some birth controls that are implants or go into the uterus. We manage period concerns like irregular periods and not getting periods, all kinds of things with menstrual cycle. We do hormone replacement for the menopausal women. A large part of what we do is breast cancer and cervical cancer screenings. So pap smears, breast exams, ordering mammograms. And then we manage a lot of common gynecological disorders. We nurse midwives have a bachelor's in nursing and then a master's in nurse midwifery. Then there's the women's health nurse practitioner or family practice nurse practitioner and physician assistant. So these are other advanced practice providers. They are similar to what the nurse midwives do, but they do not deliver babies. So these women's health providers are typically not in the hospital at all. They're all office-based for women's health anyway. And then there's a certified professional midwife. This is the out-of-hospital midwife. So home birth and birthing center. They complete an educational program that's accredited by the Midwifery Education Accreditation Council. And their education is they do an apprenticeship with a qualified preceptor, which is typically another certified professional midwife, and a certificate or associate's degree can be earned. They have very limited prescriptive authority, so they basically can only prescribe just a very few things that help control bleeding after birth. And they can give antibiotics in labor, but that's really about it. They can legally practice in 36 states and in Washington, D.C., and they do births in birth centers and home births. So they basically are pregnancy and birth out of hospital with low risk women. And then a doula, you might hear more about in the last several months and couple years here in Delaware. There's been a big push to help get doulas in the hospital and helping support these women, especially women who have barriers to getting good health care. And the doula is basically a trained professional who provides non-medical labor support during pregnancy, labor, and postpartum. Some states, including Delaware, do cover doula care with insurance. And their certification training is typically just a few days, and then they pass an exam and they become CPR certified to be a certified doula. So basically they're there supporting the woman with kind of what she is hoping to get out of the labor experience. So if she's wanting to do it without pain medication, she might be doing counter pressure on her back or massage, or she might just be putting a cold rag on her face or encouraging her. So it's more labor support. They don't provide any medical care, and they do not deliver the baby. And then within OBGYN physicians, there are subspecialties as well. So the maternal fetal medicine specialist, this is an extra 3-year fellowship. So it's an OBGYN physician, and then they go 3 more years for the fellowship. I work very closely with them, especially the ones here in Delaware. They're phenomenal maternal fetal medicine physicians, but they are who the high-risk pregnancies go see, and they do like real detailed ultrasound, and they help with guidance on management for complex maternal and fetal disorders. Some maternal fetal medicines even have specialized training in fetal surgery that they do in utero. When I was training at Vanderbilt as a student, they had a whole fetal surgery unit, which was really, really great. That's not something you see everywhere. So none of the Delaware hospitals have that, but you would be looking more at like the large medical teaching facilities, you know, CHOP and places, Philly, the really large cities. And then there's gynecology oncology. That's another 3-year fellowship. And so these are OBGYNs who specialize in managing GYN cancers. So uterine, ovarian, cervical, vulvar cancer. So all of the reproductive cancers. And then there's urogynecology. That is a 2 to 3 year fellowship. And it's going to be similar to the female pelvic medicine and reconstructive surgery, which is also a 2 to 3 year fellowship. These doctors do a lot of reconstructive surgery of the vagina. And so for all kinds of things, usually mostly women who are postmenopause, but kind of fixing things when they need to be fixed. And so it's reconstructive surgery down there for prolapse and other things. And then the reproductive endocrinology, that's a 3-year fellowship. These are the specialists that help people get pregnant who need assistance with technology to conceive. So whether that's a same-sex couple or using surrogacy, or a couple who just can't conceive on their own for a while. And so they're a whole extra specialty, and they are really phenomenal. And we have a couple practices here in Delaware who do great with that. So for why I chose to be a nurse midwife. So starting back when I was a small child, like in kindergarten, I would tell my mom I wanted to be a baby doctor. And so I was obsessed with babies. I always had baby dolls. I carried a baby doll in my backpack every day. It was just, Lisa always had a baby with her. And so I had always said that I wanted to be a baby doctor. And then when I was in high school, probably like 9th or 10th grade, the lady that I babysat for was pregnant, and she asked if I wanted to go with her to her prenatal appointment. And I did, and it was with a midwife. And I think it was probably a certified professional midwife because she did a home birth, but I don't know that for sure now. But that was the first time I had even heard of a midwife. I didn't know what a midwife was. So then I started like looking into it, and I knew I didn't want to be a surgeon. Surgery is not something that interested me. I liked the idea of managing more normal physiologic birth. But I also wanted to deliver babies in a hospital. I liked the comfort of knowing that there was help if I need it. And there's, you know, a whole team for the baby. There's just more support. So then after like looking into the different options and the different routes to go to be able to deliver a baby, I decided I wanted to be a nurse midwife. I also liked the education time frame. Being young and 16, 17 years old, the thought of going to college for 12 years seemed overwhelming. And you think, dang, I'm going to be in school till I'm in my 30s, which is not that long, by the way. But when you're young, that was a big part of it for me. And I was like, well, I could be a midwife in like 6 years. So that was part of my decision. And then the other part, I am one of 6 kids and a single mom. So we did not have a lot of finances, and none of my school was going to be paid for by my mom. So I had some scholarships, especially for undergrad, but I was going to have to fund my whole education, including books and dorm and all of that stuff. So paying for 6 years of school is a whole lot less money than paying for 12 years of school. So finances was definitely part of my decision making as well. Speaking of financial stuff, there is a Delaware student loan repayment program available. There's some information here. This is directly from their website, but they offer awards ranging from like $30,000 to $100,000 to help healthcare professionals repay student loans if they live in Delaware and work at like a federally qualified health center, kind of like Lored. Some of the hospitals in Delaware are going to qualify for that as well. And so that's a really great program. There's also a federal program, like a national program, which is what I did, the public student loan forgiveness. And so after working for a qualified facility for 10 years, making 120 payments on time, whatever's left on your loans would be forgiven. And so when I left school, with $140,000 in student loans, programs like this are definitely something to consider, because you're going to be paying a lot of money. Leaving with that much student loan debt, you pay a lot, but hopefully if you're getting a lot of student loans, you're also planning to get a job that pays well to pay them back. But after paying, a large student loan payment every month, after 10 years, if you do still have some left and you're in one of these facilities, the government does forgive the rest of it, which is really helpful in helping people like me who otherwise wouldn't have had access to an education. So I'm a big fan of the student loan repayment programs. The eligible fields are listed here for the student loan repayment that's specific to Delaware. So all of the physicians, the DO and MD and dentists, and then family nurse, or all the nurse practitioners, certified nurse midwives, and then there's some other things listed here like nurses and pharmacists, physician assistant. So a little bit about what I do on a day-to-day basis. I do a lot of obstetrical care. And so for a lot of my specific patient clientele, when they come in to get seen for pregnancy, that's usually the only time they're coming in. So they often have to get caught up on their routine cervical cancer screening, their breast exam, pelvic exams. So we do a full exam on their first visit, including some blood work, and then address any problems that come up. And then we take care of them throughout the pregnancy. Lored does not actually deliver the babies, so we take care of them, and then the local hospitals like Beebe, they deliver the babies. So the patient just goes there in labor, and then we follow up with them postpartum as well. Like I said, I do still deliver up at Kent. And so a lot of the hospitals in Delaware have moved to a hospitalist model where basically the patient comes in and they get delivered by the providers who are on call. So it's not like back in the day, a woman would see the same doctor the whole pregnancy and then that doctor would deliver them. We've kind of moved away from that because the call life is really hard. Being on call all the time, we don't want to do that anymore because you don't have good work-life balance that way. So it kind of works that Lorette doesn't deliver because the hospitals have kind of moved to that hospitalist model anyway. People hear midwife and they typically think of like taking care of pregnant women, but a large part of what we do is also not pregnant women. I see a lot of women who are having trouble conceiving, and I actually enjoy these kind of visits because you're trying to figure out what could be causing her to not have a baby. And so it's a little bit of an investigation, and then trying to figure out what you can do to help her with medication or different things that they can try. And it's extremely rewarding when you've been working for somebody with a couple for a few months and trying to get pregnant. And for a lot of them, they've been trying for a year, 2 years before they come and get help. And then to be able to help them conceive and see that joy is really special. And then also we do a lot of cancer screening. So the female exam, the gynecological exam, includes a breast exam where we're feeling for like any abnormal bumps, lumps, skin changes, and then the pelvic exam. And so for a pelvic exam, we collect a pap smear, which is where we get cells from the cervix and then send them off to the pathologist to read the cytology on that. And then I've just recently learned how to do the next step, which is called colposcopy. And so when somebody has an abnormal pap smear, now I can go in and look with this special microscope and take little biopsies of the cervix and send that off to determine what the next treatment should be for the patient based on what's happening. Cervical cancer is actually very common, one of the more common female cancers, and it is very, very often preventable if we just get people pap smears and we can get them to follow the recommendations on getting them at the appropriate interval, which generally is about every 3 years. And so, especially with learning this colposcopy, the pap smear screening has become something I've become very motivated to teach people and teach my patients that something very simple like really could save their life. A lot of times we're finding the abnormal lesions well before it becomes precancerous or cancerous, and we can take care of it before it turns into something. So some really important work in just a routine gynecological exam. I do have a funny story. A few years ago, I was working, it was the middle of the night, and I had a patient come in labor. It was like 2 a.m, and she was all dressed up. She had went to the club because it was her birthday and she wanted to go dancing. She was sober. She was taking care of herself. She was very healthy, but she wanted to go dancing. She, of course, was the designated driver because she was pregnant. And her friend was with her who had a few drinks. And so they come, she's in labor, she gets her epidural and she does really great. And we're pushing. And right as the baby is starting to come out, the friend who was holding her leg on the side passed out right into her lap. And so the baby is coming out and I'm trying to get this baby out, and this woman is passed out between the patient's legs. And so it was pretty funny, and I'm sure she has never lived that down. They were all okay. The nurse helped her get her off and she woke up and she was good. But the sight of a baby being born, especially having a couple of drinks, it was quite the scene, and we all had a good laugh afterwards. But you see a lot of really fun and interesting stuff. You see a lot of really good moments. I've delivered 4 babies for the same family. I've delivered probably 6 sets of twins, and I've probably delivered about 1,800 babies in total. So the delivering the babies is definitely one of the more fun parts of being a midwife, but I do enjoy all of the parts. Like, I like that my career lets me get a change of pace So I'm in the office some, I'm also doing some administrative stuff, and then I'm also delivering. And so it keeps things a little bit fresh. I feel like if I only did one thing, I'd probably get a little bit bored with things. And so I like that this field of medicine gives you a lot of different things. So I think that's about it for my presentation.
Thanks, Lisa.
All righty. Thank you. Thank you. Yeah. I bet she never lived that down. Yeah.
I know, I was laughing the whole time you were telling that story. I can't even
Um,
imagine.
So I imagine that's a lot of babies you've assisted in the delivery of. Wow, that's a lot. Um, can you tell us about neonatal abstinence syndrome and just that whole thing as it relates to the kind of work that you do?
So neonatal abstinence syndrome is when babies are born to mothers who have opioid use disorder. So these are women who are on methadone or Suboxone, or who are actively using opiates. So that could be pain pills, it could be, which sometimes are prescribed and they're using them appropriately. But many times it's street drugs, so fentanyl and heroin. Babies born to other drugs typically don't withdraw like they do for the opioids, but neonatal abstinence syndrome is these babies are born and they've been getting these opiates, and we know that opiates, you become physically dependent on them. And so these babies have to be monitored and then oftentimes weaned off of the narcotics so that they don't suffer from ill health effects. So like they could have seizures and not eating well and stuff. So there's a whole process that the pediatrics team and the nurses do where they score these babies based on their behaviors. So like crying and irritability and shaking, jitteriness. And so based on the scoring, they decide if the baby needs morphine. And if so, if that morphine dose can be needs to be increased or decreased, and then they really slowly decrease it to where they can get the baby off. And then the baby does get off, and these babies do have good outcomes, but it takes a lot of time and resources. These babies are usually in the hospital for like 1 to 2 months coming off of it. BB, I can speak to BB's program a little bit because I was there. They have a wonderful program, and the thing that sets BB apart is their babies stay on the unit, and so the mom or the caregiver can stay with the baby. And we know that when the caregiver is staying with the baby and they're not just put in a nursery, they have much better outcomes. They need less medication. So that's really important for these babies to have their caregiver there. And for the mothers who are planning to take their babies home and care for them and be a good parent, it's really important to have them have access to their baby and learn how to take care of their baby. And so BB's program really, really helps give them every chance at success, which is great.
All righty. One of the questions here that I typed an answer to, but I want to answer it for everybody, was to be eligible for the Delaware SLURP program, the Student Loan Repayment Program. Do you need to go to a medical school or dental school in Delaware? And the answer is no. And by the way, Delaware has neither a medical or a dental school anyway. The SLURP program is targeted for Delawareans who have gone to school outside of Delaware or to non-Delawareans who are relocating to Delaware. So that's the answer to that. Excuse me. My gracious. I am so sorry. So
Do you want me to go through and answer a couple?
yeah, sure, go for it.
So the full process for the pap smear, So the pap smear part, we have the woman, she's undressed, and there's usually there's a chaperone in the room with us, but we have her come to the end of the table so that her bottom is kind of like hanging at the edge, and then we put a speculum in. A speculum is a device that goes into the vagina and then opens up so that you can see the cervix, which is at the back of the vagina. And so we open it up and see the cervix, and then there's a little brush on a stick, and we just twirl it, and it like collects little cells. It's a real soft brush. Most women don't really feel much with it. Some women feel a little cramping. They do feel the speculum, which causes some vaginal pressure. But that's really it. We just collect the cells and then put it in a container, and that gets sent to a pathologist. And then the pathologist tells us what type of cells. Are they normal cells? Are they a little bit abnormal, but probably fine? Or are the cells like changing enough that they're more high risk for becoming cancer? And then very rarely you'll see cells that do exhibit signs of cancer, but that's really rare. A birthing center is basically a building where women go to have babies. That is not a hospital. And so it typically has like a more homey feel. There's usually like a labor tub. There's what looks more like a regular bed instead of a hospital bed. And so it's a little bit more of a home type environment, but it's not at their home. So it's a designated center. Some midwives do their prenatal care in those centers. Some midwives do prenatal care like at the patient's home. But a birth center does not have, it's not a hospital. Now, like in Annapolis, there's a birth center connected to the hospital. And so that's a little bit different and unique. But most birth centers are just opened by a midwife businesswoman who wants to do out of hospital deliveries. I'm not sure what about a doula was referring to.
I'm not sure either.
Okay. And then are the hospitalists able to connect enough with their patients at the time of delivery so that nothing is missed and the patient's OBGYN would otherwise know? Most of the time, yes. So the good thing about technology is we're getting a lot more streamlined with sharing medical information. Delaware has a program called DIN, which lets healthcare providers log in and see all testing that's been done within the state. So like if I'm working up at Kent and a patient comes in and they have no prenatal records, they didn't go anywhere in Kent, but they went down, they got prenatal care in Seaford, I can see a significant amount of their prenatal record just from that DIN website. And so I can see all of their blood work, I can see their ultrasounds and their maternal fetal medicine reports. So that's really helpful. And then almost all the time, if we call their home hospital, like where they were planning to deliver, they'll have their full records and they just fax them over. And then for follow-up, all the hospitals have their own little system, but most of the time patients leave the hospital with a scheduled appointment with their provider so that their provider knows that they delivered, they've gotten their delivery records so that their office provider knows what happened and everything. So it's not to say that nothing is ever missed, but technology is making it much better to share information and make sure that things are not missed. And so a hospitalist is an OBGYN. So the question is, what is the benefit to the patient of having a hospitalist instead of their OBGYN? So the benefit to the patient is you have a fresher person, not somebody who's been on call for 4 days straight, but a hospitalist is an OBGYN, or like I'm a hospitalist midwife up at Kent. So that just means I see everybody who comes through the door. I'm not only seeing patients I took care of in my office. So the same thing with the hospitalist OBGYN. So the OBGYN who's acting as a hospitalist is not only taking care of their patients, they just see whoever's in there, and they typically do 12-hour shifts. So you're on for 12 hours and then you're off. So you're a lot more rested. I was in a practice before where the physicians would take call for 7 days straight and then off for 7 days. So they only came in when their patients were in labor, which you might get called in 4 nights in a row, or you might not get called in at all that week. And so that's the benefit to the patient for having a hospitalist is you don't have a physician or midwife who's exhausted and maybe not on top of their game. And then the huge benefit is to the practitioner. Like I was saying, the work-life balance, when you have to take a lot of call and be in the office, it takes a toll on you. When, you know, one of my first jobs as a midwife, I was working like 60 to 80 hours a week, and that's not sustainable. And they don't do that anymore. But 20 years ago, that was normal for OBGYNs to work 60 to 80 hours a week. And so luckily there's been a shift in that, and people are finally realizing that we don't have to be martyrs. We can be really good practitioners and give really good time, but also we deserve to go home at the end of the day and have families and be normal people too. Do you help deliver babies who are breech? I'm trained to deliver breech babies. All midwives and physicians are trained to, but typically breech babies are done by C-section because it's safer. I've done 2 breech deliveries, but they were demises. So babies who had lost their heartbeat, and so they were being induced to deliver, and they were very small. They were like less than 20 weeks. So I've never had to do a term or a breech delivery of a baby who's full term or almost full term, just because they're usually taken for a C-section. Do I take care of high-risk women? I do. At Lared, we don't have any physicians. It's midwife-run practice. And so we take care of everything. So I manage insulin for our diabetics, gestational diabetics or pre-existing diabetics. I manage high blood pressure and titrate medications for the high blood pressure. Those are the 2 more common comorbidities, but yeah, everybody's high risk nowadays, it seems. And so we do a lot of high risk. We do a significant amount of low risk too. And there's a lot of variation in high risk. You know, some people are just a little bit high risk. And then some people are really sick and unhealthy, and there's a lot of risk to the pregnancy. And those I co-manage with a maternal fetal medicine specialist. So I do their prenatal care, and then they see the specialist for their ultrasounds. And then the maternal fetal medicine specialist makes recommendations on like when to deliver that patient, get these extra labs, or start this medication people. And so some high risk things I co-manage with a maternal fetal medicine doctor. At what age do people typically see a gynecologist? So there's a couple answers to this. I would tell parents to bring their kids before they start having boyfriends or girlfriends, because they need to learn about safe sex and learn that there's a safe place to talk about it. So if I have a patient who's interested in, getting into a relationship, and there's even a small possibility they may become sexually active, I want to see them beforehand. But I do not do a pelvic exam. We don't do pelvic exams until 21, unless there's like a problem that needs to be looked at. But for a vast majority of women under 21, we don't do pelvic exams. We can do STD screenings off of a urine sample. And so before 21, the visit is just counseling, talking to them about birth control options and the benefits to each of the birth controls, and the side effects, and then figuring out what works best for that individual person. And sometimes they're not ready to start, but at least they have information. And then it's talking to them about like what to expect when they do get their first pelvic exam. And then we start pap smear screening on everybody at 21, all women at 21, whether they're sexually active or not. But if somebody's sexually active before 21, we do not start pap smears before that. So everybody starts at 21. As far as the services provided via LRED, do they apply for the visa or the MSFW agricultural workers? I don't know the answer to that. A lot of them are in the immigration process, but it's really hard to get like citizenship because of where they're from. And I don't know the ins and outs of it. I know like the Haitian Creole women who come in, they have a much easier path to citizenship than like our women who are coming from Mexico and Guatemala. We do help them apply for emergency Medicaid and WIC. When their babies are born, their babies are citizens and they do get benefits, so they will get Medicaid and stuff like that. So we help with all of those things. But we typically don't deal with any immigration stuff. We want to be a place where these patients can come and get taken care of and not have to worry about immigration. We don't want them to be scared to come and see us. We want them to just receive health care. They're human beings and they deserve to be taken care of. And so we don't really ask about immigration status. Can you talk about if you see patient preferences for male versus female? Occasionally there's somebody who only wants a female, but most of the time people don't care, especially when you're there for a medical procedure or an exam, especially when you're just ready to have the baby. Usually by that time the woman just says get it out. I'm ready to not be pregnant anymore. So occasionally there'll be somebody, but most of the time they don't have a preference, or they're fine if it is a male. The way the hospitals deal with it, if there is a female provider there, they will accommodate. But all the practices I've been at, they will tell the patients who have that preference, we will try our best to accommodate, but there is no guarantee. You know, if BB only has one doctor on and it's a male, he's the one on call. And so the patients are told that up front. And if they don't want any chance of having a male provider, then they should look at their other options, because that's not always a guarantee for most of the hospitals. So do I do IVF? And does Delaware confine to offer IVF? Is it difficult or painful? So I don't do IVF. That's the reproductive endocrinologist. So that's an OBGYN subspecialty.
What does that stand for?
Oh, in vitro fertilization.
Thank you.
So that's people who need assistance getting pregnant. There's lots of ways to get pregnant. There's intrauterine insemination, where they just get the sperm that's been like concentrated and they just inject it into the cervix, so it just gets much closer. That's much cheaper and a little more simpler than the IVF. IVF is they have to harvest eggs out of the ovary, which is a surgery for the woman, and then they have to get the sperm from the male donor, whoever that is, the partner or whoever, and then in a petri dish or whatever, they make the sperm and the egg meet, and then they grow it for 3 days and then freeze it or implant it. It's very complicated. It's above my pay grade. OBGYNs do not do IVF. You have to have the subspecialty of reproductive endocrinology. So that's a whole nother thing. Some insurances pay for fertility treatments. Some insurances pay for some fertility treatments, but not IVF. And then some pay for a certain amount of rounds of it. And then many insurances do not pay for IVF. So in somebody who has coverage for IVF, they typically still spend about like $5,000 to $7,000 in copays for the medications, which are very expensive. And then women who do not have insurance coverage, which are many, IVF last I heard was typically around 20 to 25,000, and you're not guaranteed a baby. IVF does not work every time. And some people need multiple rounds. So that some people, it might take 3 different rounds of IVF before they have a live birth. Do I see women with fibroids and polyps? And if you do, what's the plan of action? So I do. Fibroids are very common. About 30% of women have fibroids. They're more common in African American women, but all women of all ethnicities get them. And a lot of fibroids are benign tumors on the uterus. And so benign meaning they are not cancerous. For many women, they are not bothered by them or not bothered enough that they want anything done. A lot of times we will find them incidentally. So we'll get a pelvic ultrasound for something, including pregnancy, and we'll just say, oh, hey, you have a fibroid or you have a couple fibroids. Fibroids can cause really heavy periods, painful periods. So there's a few treatment options. The first line treatment is medical management, which is when we give you hormonal birth control to help control the bleeding and cramping. That does control things pretty well for a lot of people, but not everybody. And then there's a surgical procedure that an OBGYN does called a myomectomy, where they surgically remove the fibroids. That is done in women who still want to have babies. It is not done if you're done having babies, because those fibroids will grow back. So it's not a permanent fix. And so the other treatment, the curative treatment, is a hysterectomy and taking the uterus out. So if I have a 44-year-old who's done having babies, she's going to get a hysterectomy if she wants them, if she's having problems with the fibroids and doesn't want them anymore. But if I have somebody who's 30 years old and she's trying to get pregnant, she's more of a candidate for the myomectomy to treat it. Polyps are, I treat some polyps. Sometimes we can see cervix polyps. So the cervix, again, is at the back of the vagina. That's where we collect the pap smear. And a polyp is like a little growth of tissue. It kind of looks like a skin tag almost. And we just twist them off. They're super easy. They hardly bleed usually. And then sometimes women can have a polyp in the uterus. If they're before menopause, sometimes we can watch it and they'll just go away on their own with a period. And then if they're postmenopausal, so not getting periods anymore, typically like around 50 or 55, it's recommended to remove the polyp inside the uterus with a D&C. A D&C is a surgical procedure done by a physician, not a midwife, but the patient's put to sleep and they just dilate the cervix a little bit and then scrape out the uterus and get it out that way. We typically take them out after menopause because a small percentage of them could turn into cancer if they're left there. So most polyps are very benign and not cancer, but we do take them out just because there's about a 5% cancer risk in the future. At what age is pregnancy considered high risk? And what's another term for older moms? So high risk is teen pregnancy, so 19 and under, and advanced maternal age, which is 35 and over. It's considered high risk because there's some increased risks on certain conditions, but it doesn't mean you shouldn't have them. We have many women who are teenagers having healthy pregnancies, and many women 35 and older who are having very healthy pregnancies too. But the increased risks are similar for both. There's increased risk of blood pressure issues like preeclampsia, which is when your blood pressure goes up, increased risk for preterm labor, small babies who don't grow as good as they should. If for advanced maternal age or women over 35, there's also an increased risk of chromosomal abnormalities like Down syndrome. So there's screening tests to test for that when you're about 10 weeks along or after. So they're high risk, but very manageable. And we see that's one of our normal high risks that we see very often. what are the different and unique treatments when it comes to menopause and how it affects women, especially mothers? So menopause, normal age of menopause is 45 to 55, and average age is about 51 and a half. With most people hitting menopause in their early 50s. Menopause is when you stop getting periods for at least 12 months consecutive, like 12 full months with no period. Many women don't want any treatment, and that's great and that's fine. And then there's plenty of women who do. So everybody handles the hormone changes with menopause differently, but menopause causes mood changes, vaginal dryness, which can cause painful intercourse, hot flashes and night sweats, and memory changes. They have decreased energy, skin changes. So there's a lot of things that can happen because of these hormone shifts. So we will do hormone replacement, which is estrogen and progesterone, which is the same hormones that are in birth control. Hormone replacement is very safe for a vast majority of women, and very effective, and it has lots of health benefits as well. And so I talk to my patients about the risks and the benefits, and then they, together we'll decide if it's a good treatment option for them. But typically hormone replacement is a really great treatment option for women who are having issues, and it helps decrease heart risk and decreases the risk of certain cancers as well. I am not published. I don't have any articles on hand, probably mostly because I don't work in a educational facility, and but no, I'm not published. When you say everybody's high risk, what do you think the cause is to this high risk trend pregnancy? And as an OBGYN, what can they do to prevent it now to keep it low? So we have a lot of unhealthy habits in America. So basically I'll list some of the common high risk things, and it kind of puts a lot of people in it. So teen pregnancy, 19 and under, women 35 and over. So there's the age related risks. Moms who have multiples, so twins, pregnant with twins, any chronic medical condition, so high blood pressure, diabetes, pre-diabetes, thyroid issues, lupus. Any chronic disorder makes you high risk because we're managing something in addition to the pregnancy. And then the big one is obesity, which makes a lot of people qualify. So a BMI over 30. And for most women, that's not that big. And so that makes you high risk too. So the best way to decrease your risk is to eat a healthy diet, maintain a good weight. But some things are unavoidable. Sometimes you just want to have a baby and you're 36, and that's okay. And sometimes your BMI is 32 and you're healthy, and it's okay to have a baby, even though you'll be deemed high risk. So high risk just means you're not completely normal, and so you have slightly higher risk. But most of these women are having very healthy and normal pregnancies. So a vast majority of our women who are teens or over 35, or the BMI is over 30, or they're well-controlled hypertensive, they have very great pregnancies and healthy babies, and we encourage them to have as many babies as they want. Do you or Lorette offer counseling for like rape, incest victims, and or pregnancy? Yes, we have a behavioral health team. Last week, John, our behavioral health department lead, he leads that department, but we have a great team of therapists and practitioners who can prescribe as well. So we often refer to our behavioral health team for counseling. I usually, like, if there's something like rape going on, often the OBGYN provider is the first line. And so I will talk to the patient in the room and kind of talk them through what happened and what do they want to do. Do they want to report? Do they want a nurse exam, like a trauma exam, a SANE exam, which I'm not qualified to do. So that's done in the ER, and that's a sexual assault exam. Then I asked, do you want to see a therapist? Some people are ready, some people aren't. Some people want to report, some people don't. And my job is to support the woman and I don't want to push them into anything. I want to tell them options and help them make the decision that's best for them. And everybody's going to be different. But luckily, we have a really great behavioral health team. With the immigrant population, there is a lot of sexual trauma, especially as they're trying to get into the United States. And so, unfortunately, our behavioral health team has a lot of experience with this, but they are good at helping, which is the benefit. If a 16-year-old isn't sexually active, but their family has a history of cervical cancer, would that be an instance where you would do a vaginal exam? No. So cervical cancer is not hereditary. Cervical cancer is caused by HPV, human papillomavirus. Most specifically, they're almost all caused by two specific types of HPV, 16 and 18, and you get it with sex. HPV is extremely common. 80% of individuals will have HPV at some point in their life. So yes, it's transmitted by sex, but it is not like a gonorrhea or chlamydia. If you're sexually active, you've probably had HPV, even though you don't know it. But the good thing is our immune system usually clears it on its own. So like if I do a pap smear on a 21-year-old and it's a little bit abnormal and she has HPV, I don't do anything about it except repeat that pap smear in a year to see if it's still there or if it's getting worse or if it's going away. 90% of the HPVs will clear within 3 years. So
can you talk about HPV vaccination?
Yeah. So HPV vaccination is recommended to get when you're about 12 years old, and it's a series of 3 vaccines. It is our first preventative cancer vaccine, which is phenomenal. Unfortunately, cervical cancer is common. It's one of the most common GYN cancers, and everybody is at risk. Also, boys and men are not tested for HPV and not treated for it. So even if you have a son, he should be getting the vaccine because your future daughter-in-law could have cervical cancer because of him. It's a very safe and well-studied vaccine. It's been out for a long time now, and it drastically decreases your risk of cervical cancer. So it's a really phenomenal disease, and I think we're going to really see the huge benefits in it in the next like 10 to 20 years when the girls who were getting them when they were young, before they were ever sexually active, once we start seeing these women in their 40s, 50s, 60s, I think you're going to see a drastic decrease in the cervical cancer rates in that population. We're not seeing it as much yet because cervical cancer takes a while to develop. So like if you are exposed with HPV in your first sexual encounter at 19, it's not going to be for many years, probably 10 plus years before it turns into a high risk lesion. And then a few years later before it turns into precancer and then cancer. So we aren't going to see the great decrease in numbers until that generation is a little bit older. Is there a period of the month where there tends to be more women going into labor than others, and can environmental factors like hurricanes affect a pregnancy and cause them to go into labor? The summer is always busy. September is the highest birth month, like nationally, but I will say summer sucks. You're busy, very, very busy. And then it does get a lot slower around the holidays, which is kind of nice if you don't want to be busy. But like I just worked last week, so the end of October, in a 12-hour shift overnight, I delivered 5 babies. So like there's busy times all the time. It's but summer tends to be the busiest. Sometimes I don't think weather affects it. You will hear people in the medical field saying if there's a full moon, watch out, but there's really no correlation. I will say when there's like a hurricane or bad weather, it's usually a good night because people don't come in unless they really need it. So you get a lot less of the silly visits that you're like, well, this could have waited for your doctor tomorrow at the office. So typically, adverse weather, whatever comes in tends to be just real labor, and you have a lot less of like frivolous stuff. If a young woman has dense breasts, will they lose density as she ages? You'll lose some density. So like if a woman comes in who's 26 and she has a breast lump, her breasts typically are too dense to get a good mammogram. The mammogram's not going to tell enough. So we start with an ultrasound, and then if it's anything suspicious, we go to an MRI. But after 30, it's a little bit easier to read that mammogram. So breast density will change some, but some women just have dense breasts. And so even in their 60s, they have dense breast tissue. And that's just genetic. It's just how your tissue is. How long does it take to start seeing results when using contraceptive for fibroids? Everybody's different on that. Some people within the first month, they notice some slight improvement, but typically to get the best effect, you need to be on birth control for at least 3 months before you start seeing good effects. Some people will still notice a little bit more effect after. And then there are some people that birth control just doesn't do enough. And those are the people who have to talk about other options like surgical options or trying a different birth control. What would you recommend for a woman who had polyps due to low progesterone, or would you prescribe that was more holistic? So I don't do much holistic medicine. I practice more medical medicine. So I'm not sure about anything holistic that would help, but polyps, it would all depend on where she's getting them and how often. Like it's a complicated answer. She would need a full workup to answer that. So somebody like that would need to make an appointment. What's the oldest woman I've seen for delivery? I've delivered a 46-year-old, and she was IVF. Your chances of spontaneously conceiving at 44 and beyond is about 1 to 2%. So it's possible, but it's not super common. But so the 46-year-old I had was IVF, and she used a donor egg. So it was somebody else's egg, and then she carried the baby. It was her husband's sperm, somebody else's egg. The problem is as we age, our eggs kind of lose quality. And so much higher risk of chromosomal abnormalities and much higher risk of miscarriage. The risk of miscarriage after 40 is a lot higher. Does hormone replacement happen after women have been on menopause for 12 months, or can they do it earlier? So hormone replacement we don't start until 12 months after no periods. But if somebody's really symptomatic, we will often talk about like starting a low dose birth control until she gets to menopause, because they're both the same hormones. It's just different dosing. So there are still options before menopause. Could you give us an idea on eating disorders can affect fertility in women? Yes. So eating disorders definitely affects fertility. So anorexia and bulimia, when you're starving your body, your reproductive system doesn't want to work. It's trying to save its energy for more basic function. So your body is going to be saying, your brain needs to work and your heart needs to work. So I only have a little bit of nutrients. I'm going to put them all to the most important things. And so oftentimes women with eating disorders have no periods or very infrequent periods because their body is trying to save the energy. And if they are still getting periods, there's a chance that they're not ovulating. So oftentimes if they get treatment for the eating disorder with, a mental health practitioner and get that under control, and they start to gain a little bit of weight, even just gaining a little bit of weight, sometimes they'll get pregnant really quickly. Obesity can also affect fertility. So that other end of eating disorders, oftentimes women who are having trouble conceiving, just if they can lose 5 to 10% of their body weight, their chances of conceiving drastically go up. It's not to say that that's the only cause, but oftentimes losing weight can help. What are the rules concerning the right to the afterbirth? So all hospitals will let you take your afterbirth. Some of them make you sign a paper saying you're taking it, but we don't care. A lot of us think it's kind of gross, but more power to you. And I support women. I've seen the studies on like encapsulation of the placenta to help with postpartum depression and bleeding and the hormone changes. It may help a little bit. So if that's what the patient wants to do, then great. I'm all for it. But the hospitals don't provide the service. We basically just let you take it, and you have to find somebody. So like a doula or a home birth midwife, some of them offer that service, and they literally buy a meat dehydrator and dehydrate it and then crush it and put it in capsules. And so you have to be careful where you're getting it done, because it is a human organ, and you really need to trust the person you're doing it, because somebody else's human organ was in there before. So that's the disclaimer I give patients, but the hospitals don't care if you take it, it's yours. For the cervical cancer question, oh, she meant uterine. So history of uterine cancer. So uterine cancer is hereditary. Uterine cancer is very rarely found young. So in somebody who was 21 with a family history of uterine cancer, if she had no red flags, I would not start an exam sooner. Most uterine cancers happen post-menopause, like a vast majority of them. And so for a 19-year-old to have uterine cancer would be extremely rare. But if I had a 19-year-old who had really abnormal periods and we try a couple months of birth control and they're not better, well, then that lets me know I need more of a workup. So pelvic exam, a pelvic ultrasound, that kind of stuff. So it's something that we would take note of, but really the family history of uterine cancer is more of something that we would be concerned of, like when you're 30 and older. What happens if you get a UTI and it goes untreated? In pregnancy, we worry about an untreated UTI turning into pyelonephritis, which is a kidney infection, which requires hospitalization and IV antibiotics. It can make you pretty sick. It can eventually lead to sepsis, infection in your blood, which you can die from. That's very rare. But usually if you get pyelonephritis, you feel terrible. You have high fever, you're super sore, your kidneys are killing you. So if you have pyelo, you're probably going to the hospital. You're really, really uncomfortable. Outside of pregnancy, the same thing could happen. It could lead to kidney infection or even kidney damage. But hopefully you're getting uncomfortable enough before it turns into that. What are some causes of vaginal dryness? Could this dryness lead to an unsuccessful pregnancy? So no, vaginal dryness won't affect the pregnancy. The most common cause for vaginal dryness is menopause. So that's the women who have stopped getting periods. There's great treatment options for it. The most effective treatment is vaginal estrogen, but there's also great treatments like Replen's vaginal moisturizer, which is kind of like a moisturizer. Think of like a lotion, but it's for the vagina. For women who are not menopausal, vaginal dryness, you would need an exam to see if there's a reason, like a yeast infection. And then sometimes they just need to use a good lubricant. Sometimes they need to use like a Replen's vaginal moisturizer. So it depends on the reason. Sometimes your vagina is dry in pregnancy because of the pregnancy hormones. Dryness with breastfeeding, also very common because of the hormone changes. So sometimes you just have to make do with lubricants until you're done being pregnant or done breastfeeding, and then it gets much better. But I have prescribed vaginal estrogen for a 30-year-old because the vaginal dryness was just too uncomfortable from breastfeeding and she was miserable. So there are treatment options, but it does not affect the pregnancy. What age is yeast infection common? Any adult woman. Very rarely I'll treat like a preteen or something for it, but any woman. It's a moist area, and so yeast can grow. You can get yeast from anything. Some people just using a new lubricant. Some people used a different soap in the shower because they were at a hotel. Like, yeast infections are just common, which is why they sell the Monistat over the counter. But so any age, it's more common in pregnancy just because of hormone changes.
All righty. Well, Lisa, thank you very much. Excellent presentation. Lots of interesting information there and handled all with a smile. Appreciate it. Next week, we have Catalina Figueroa, who's a community health worker and a colleague of Lisa, I believe. And we look forward to seeing you next week. This evening's session will be posted on Delaware MiniMed probably about this time tomorrow evening, if not sooner. Take care, everybody. See you next week. Bye-bye.